Thank you everyone for joining us tonight. We are going to be having what I believe will be a very enlightening conversation. I'm excited to introduce everyone to our panelists, but first I'm going to give a brief background of who we are and what led us to having this discussion tonight. For those of you who are new to Pieces of Me Foundation, we are a young nonprofit dedicated to erasing the stigma surrounding disability and chronic illness. We are a community where everyone can thrive regardless of their characteristics. And part of erasing stigma comes from simply getting knowledge out there. It comes from erasing misconceptions so that new insights can take their place. And to that end, I'm really excited to be having this discussion tonight. For those of you who don't know me, my name is Daniel Hodges. I am the president and co-founder of Pieces of Me. And before there was an organization, there was this vision of mine of practicing at the intersection of healthcare and civil rights based on my experience as a blind person with a connective tissue disorder that took forever to diagnose, and a million stories that go along with that, and so many other things that I had witnessed in friends and family and loved ones that just, they weren't living up to the standard that we should have for how one accesses the healthcare system. So this ties into that really well. So I'm really grateful to have our speakers with us tonight. So I'm going to start off by having Ms. Sherry James introduce herself, followed by Dr. Laura Hoffman and Professor Barbara Cornball. I'm going to tell you a little about who they are and why this topic is important to them. And we're going to go from there.
Thank you, Daniel. Thank you so much for having us here. This is going to be an amazing call. Thank you for having me as a part of this panel. As David mentioned, my name is Sherry James. I am the founder and CEO of the nonprofit 2020 Lives Changed Incorporated. We focus on powering up organizations with the tools that they need to make sure that their teams are mentally wealthy, and also including mental disabilities as a part of their diversity, equity, and inclusion programs. So I am based out of Dallas, Texas, or a little bit north of that. And I have been speaking on this topic for about 20 years in total as it applies to diversity, equity, and inclusion. And I'm very excited to be a part of this panel. So thank you, Daniel.
Fantastic, thank you.
I'm
Laura,
next, right, Daniel?
Yep.
Did you want me to go next?
Go ahead.
Thank you so much, Daniel. It's such a pleasure to be here. My name is Laura Hoffman, and I am a visiting professor of law at Cleveland Marshall College of Law in Cleveland, Ohio. I'm very thankful to Pieces of Me Foundation for the opportunity to be with all of you tonight for this discussion. Disability issues are near and dear to my heart. Similar to Daniel, I actually started pursuing law because I wanted to practice in disability law, and I ended up taking a little bit of a different route and a detour, and I actually teach law. My focus of my writing has been disability law issues, mostly focused on access to healthcare issues. So I really try to bring attention to these healthcare issues, especially now as we're moving into a time when we are seeing the intersection of technology and healthcare. And I'm just delighted to be a part of this conversation tonight.
Fantastic. It is great to have you.
Daniel, we're doing introductions. I'm sorry.
Yeah, that's right. Go ahead.
This is Barbara. I'm Barbara Kornblau. I am an occupational therapist and an attorney. And like Laura said, disability issues were something that I was brought up with. I'm kind of old. And when I was a kid, we had in my elementary school, it was accessible. It was one of the only schools in the Queens area, New York City, that was accessible. So we had kids in my classes who were what they called at the time, which is a horrible term, but it's descriptive. They called them thalidomide babies. So some of them had like a hand coming out of their elbow, some had a foot coming out of their knee. And I just thought that was normal because that's what I grew up with. So I thought, you know, you have a disability, some people have one arm, some people have a hand, some people, whatever. And then when I went to middle school, those kids disappeared. And I said to my mother, what happened to Billy and Susie and Maria? And she said, well, they are wheelchair users and your school's not accessible. And it's, what does that mean? And so I kind of learned that very early in life, and I thought that was really unfair. And that was before I ended up having a disability myself. But I've always been an advocate for disabilities, and my background as an occupational therapist, I went up to my professor and said, why are we teaching people to use telephones if they can't get into phone booths? And some of you are old enough to know what that means. And my teacher said to me, my professor said, we were in Madison, Wisconsin, and she said, go up to the state capitol and go see Representative Jim Wehner and tell him you want to work for him. So I did. And I found out that he wrote the first curb cut bill in the country. He was campaigning and he went to someone's house and they buzzed him in, which we're talking about in the early 70s. Nobody buzzed anybody in. And he went in and he starts talking about, I want to do this and I want to do this. And the guy said, I don't care. I'm a wheelchair user. I want curb cuts. And he said, what's a curb cut? And he told him, he said, I'll write a bill for that. So he wrote the first curb cut bill in the country. And I started working for him as an occupational therapy student, because I asked my professor, why are we teaching people to use telephones if they can't get into phone booths? And she said, go see Representative Jim Wehner. You need to work for him. So I did. And learned a lot and was able to write bills. I came up with an idea. He said, go for it. And so Wisconsin kind of led in the early days, and now it's nice to see these things becoming national. So.
Awesome. And Barb, I'm going to kick this back to you in a second. And one of the things that we've talked about previously is the lack of accessibility in healthcare facilities. One of the statistics I cited in a paper that I finished law school with showed that as of a couple of years ago, only 13, and that's 13% of facilities in the state of California were actually accessible to their patients. And there's no reason to believe that that's an outlier in any way, shape, or form. That seems to be consistent across the country. So, Barbara, I'm going to ask you to kind of opine on that. And I know you have a very powerful story that illustrates the kind of impact this has.
Sure. Sure. I actually have 3 stories if you let me tell them, but the first one's the most powerful. So, sometimes I'm an occupational therapist and sometimes I'm an attorney, and it just kind of depends on what day it is and who I'm working with. So I was representing Debbie. Debbie was an accountant at Jackson Memorial Hospital in Miami, and they wouldn't promote her. She was a wheelchair user. She was a C5-6 quad, and they just never promoted her. They kept passing her over for promotion. So she contacted me and said, I want to sue them. This isn't fair. I'm qualified. I said, sure, fine. So I was working with her as a lawyer, with my lawyer hat on her lack of promotion. And she called me one day and she said, put on your OT hat. And I said, okay, I got it on. What can I do? And she said, I've had vaginal bleeding for 4 months and I can't find a doctor to do a pap smear on me. And I said, well, let me make some calls. I'll transfer you to the table. I'll hold your legs up, whatever we need to do. Let me help you. So I found a doctor who was willing to give her pap smear. I transferred her to the table. I held her legs up. And lo and behold, she had stage 4 cervical cancer, and she died about 6 weeks later. And I have her permission to tell her story and use her name, because I told her that she's not going to die for nothing. That we're going to try and use her story to see if we can change the world. So one of the things that I did, when the Affordable Care Act was on the, being devised or put together, I went to the HEA group, the Health Equity and Accountability Act group, which was mostly, at that time, it was all racial and ethnic groups. And I tried to get them to include in their advocacy disability. And I said to them, nobody's one thing. You can be purple and have a disability. You can be green and have, something else. Nobody's one thing. Everybody's affected by this. So basically, they kicked me out of the room. These 2 guys were in my face and saying, what are you doing here? So I, said, okay, I'm leaving. I hope your grandmother doesn't die because she can't get a mammogram or a pap smear. So I was able to, I put together a coalition and we got the word disability in the bill every racial and ethnic appears. And after that happened, they welcomed me in the HEA coalition, and they put me on the panels and the executive committee, and we accepted the fact that nobody's one thing. Intersectionality became a thing. Now, since then, um, we did get in the bill to have accessible medical equipment, but we didn't make it mandatory. It's voluntary. Obama was going to make it mandatory, but it didn't get done in time. And, when Trump came in, it just wasn't important to him, so it didn't happen. So hopefully that's something that we can eventually do. The two other stories I want to tell you about medical equipment. I worked for Senator Harkin, and we got a bunch of letters when we were working on the Affordable Care Act and some other things. So one of the ones I got was a guy who he just turned 50, and now it's 45 that you have to get what do you call it? A colonoscopy. Then it was 50. So he was the C67 quad. He did all the clean out you need to do. And those of you who are young, it doesn't look like a lot of us are young, but there's a few. When you get a colonoscopy, basically, excuse my French, you poop your brains out, all right, for 24 hours. And if you're a wheelchair user, you have to sleep on the toilet. Okay, I slept on the toilet the last time I did that. And I'm not a wheelchair user, but I have a disability that doesn't allow me to get up and down as easy. So this guy, gentleman slept on the toilet, went to the colonoscopy clinic the next day, changed his clothes, did everything, went into the room where the colonoscopies are done, and they looked at him and said, we don't have a way to get you on the table. So here's a stool sample cup. Bring it back next week. The third story is a woman who is getting on in years, and she had a physical, and she was also a wheelchair user, and she wanted to get weighed. Everybody wants to get weighed at some point in their lives. They want to see if they need, I feel like I'm overweight. Let me see how much. I want to lose weight. I can measure it. So the doctor said, well, I don't have a way to weigh you. Why don't you go to the post office and see if they'll put you on the mail scale? So she did. She went to the post office and she said to them, can you weigh me on the mail scale? And they said, lady, we only weigh packages. We don't weigh people. And, when you consider that these are normal things that, the average Joe goes to the doctor, and what do? They get weighed. They get referred at 50 or 45 now, they get referred to get a colonoscopy. A woman gets a pap smear. But that doesn't happen if you have a disability, and that's wrong. That's just wrong. And I just can't see it. It's kind of like saying that if you're bleeding, we're not going to give you stitches. It's the same thing. And I just don't see how people can accept that. And I'm trying to change it. We're all trying to change it. But what I'm hoping will happen is that the standards for accessible medical equipment will be made mandatory. And I know that that's something that the National Council on Disabilities is working on. They want to make those things mandatory. And it's just kind of silly because if you said that you weren't doing it, we're not going to do colonoscopies on people because they're Jewish, they're black, they're this, they're that. No one would accept that. It's absurd. But if you say we're not going to do it because you have a disability, it's okay. It's not okay. And people are dying. Literally, people are dying. And that's something that I'm trying to change that. And hopefully we can eventually get there. And I'm hoping, one of the things I said to Debbie when I asked her if I could tell her story is I said, I want to try and change the world. You're dying. I'm hoping that your death is not going to be in vain, that we can change the world so that other people with disabilities who follow you don't have to die because they have a disability. I mean, she was 31 years old, by the way. I don't know if I said that, but who dies at 31 of, not having a pap smear of cervical cancer? Who does that? Doesn't happen. Even in third world countries, that doesn't happen. So why does it have to happen to women with disabilities? It just shouldn't happen. And it's probably similar for women with breast cancer because they can't get, they can't get breast exams. They can't get all kinds of tests that people just don't think about doing, because if you have a disability, what do you need a test for? You already have a disability. I mean, just crazy stuff that I've tried to sell it to medical students, and it just doesn't always, it doesn't get anywhere.
And Daniel, if you don't mind, I'd like to kind of piggyback on what Barbara just said. If
Absolutely,
you're
go
okay with
for
that?
it. Yes.
Awesome. And so Barbara did mention, thank you so much for those stories. They're very painful to hear, definitely. But I want to talk about a little bit about the intersectionality comment, right? And so as a woman of color, as a minority who, you mentioned how young we were. I'm no longer young. I passed the 50 mark. So I think I can fit in the older people club, right? But I've had some experiences personally, as well as just kind of in the research and the work that I've done around the inconsistencies in healthcare treatment based on, the zip code or the area code that you live in, based on the color of your skin. I told a story, one of the organizations that Daniel and I are a part of is the C-Suite Network. And we had a call and I talked about how differently I was treated at a hospital based on my pain tolerance, right? And I have a lot of friends that look a lot of ways, and they have different experiences, right? And so when it comes to that intersectionality, I love the fact that we're having this panel, so we are actively working towards change. And so I want to first, before we go too far, tell you guys that I appreciate this opportunity to not only talk about the problem, but come up with some possible solutions. And so the experiences, and I won't go into my horror stories that I've experienced being a woman of color and also disabled, but I will tell you that I think, and I don't want to jump the gun, but one of the things I wished our allies would be able to do is ask better questions, right? Most professionals, most C-suite executives, especially in their own organizations, if you were only to ask questions of your human resources department. I worked for a very, very wealthy company at one point, and I had a stroke, and I had to get in and out of this building, which was a very gorgeous building. It's in the middle of uptown Dallas, brass and glass and marble, and all of the things that you just aspire to be a part of that work environment. It was not ADA accessible, so getting in to that building in a wheelchair, up the elevator to my office was literally took my entire team almost every day, right? But I will say that the leadership at the organization was willing to have a conversation to pull the data to see how many people in that building overall, were there, how many people would need to have that kind of access. And so from an intersectionality perspective, ask those questions. As we are doing this work as it applies to disabilities, ask the questions. For example, I forwarded Daniel something from Mental Health America today, and it talked about the increased number of African-American women that die during C-section births, right? So this is a data point. I'm one of those persons that believes in getting data. So asking the why, finding out if it's a hospital that is near you, that you just want to know, and if you're working in the space, how many women each year die during a cesarean birth? Right? And then find that number. It's already, captured in their HR, in their database somewhere, right? How many of those are then persons of color? And then once that data has been exposed, now you can ask a question about what we can do to change it. So as it applies to intersectionality, I encourage everyone on this call, everyone who has the chance to listen to this call even later, ask questions to compile data, because only with that data can we drive change, right? That's the only way we can go to, like Barbara said, go to your government officials and say, hey, here's what we need to do based on this information, as opposed to our personal stories, which are impactful and they're visceral and they make us feel something. But if we really want to have change, I encourage us to make sure that we're gathering the data proactively to support our cause.
I'd like to add to that intersectionality, if I may. I'm actually, I'll tell you all outright, I am 75 years old. So I have now added age onto other multiple disabilities. Okay, started with spine and neck broken when I was only 18 years old. And then other things including last year getting a pacemaker put in. I use what's reputationally and by experts, the magnificent hospital and specialists at Johns Hopkins in Baltimore, and have run into disability problems. And luckily, I'm on their PFACs, their patient family advisory committees, although a lot of things, some things they're not in common with the other people on the committee, so they don't make it out of committee quite often. I'll give you a perfect example. Because of other issues I've had eye and face and head cancer and radiation and things. I need an MRI scan now every 3rd year. I always have to be given anesthesia to knock me out because I have rods in my spine that go from C3 down to T2 and then others that are lower. So the anesthesia people have an MRI they're connected to. They knock me out, they knock out the children, the pediatric patients, and people older than me. But that machine doesn't allow a pacemaker. Their only machine that has a pacemaker capability in an MRI is in a different building. And in order for me to get an MRI in that machine, because I'm 100% pacemaker dependent, they'd have to take apart their anesthesia setup at the other MRI, move it to the other building, set it up, test it, use it on me for 2 to 3 hours, take it down and put it back. In other words, an entire 8-hour shift, stopping 2 locations. It's frightening. So that, in addition to everything being blamed on age, and most of my things aren't age, whether it be and they assume I use wheelchairs and scooters and crutches because I got old. And I go, oh no, I was far younger than you. I've spent 50 some odd years doing this. So although it's not a disability, I'd like us as a group, Gary Norman is the one who invited me in to join it. I'd like us to throw in, as the last 2 speakers mentioned, although it isn't a disability, we have, just as pregnancy is not a disability legally, we need to throw in ageism because it's being used as an excuse to not treat people and not take what's wrong seriously. And it's frightening me as I chug along here. Thank you.
I appreciate that. And I'm actually going to throw in an extra question based on what you said, because I think we do need to talk about the role of implicit bias. And we hear it thrown around commonly in a variety of contexts, but it's not well understood within either the disability or the ageism conversation. So I want to open that up to our panelists as well, if any of the 3 of you have something to add there.
I'll just start it off with a quick sentence. I don't think it's bias. I really think that what happens is half the people involved in the decision making, and I come out of a corporate as well as a federal background and university teaching, half the people couldn't care less. It's not their problem. But it has nothing to do with medical or us or our issues. They don't care about anyone. Okay, and we have to understand that. They're not picking on us. They are just self-centered and they don't care. The other half of the people don't consider any of these things until they do bump up against a personal instance and then go, oh, that's terrible.
I'll make some comments, Daniel. First of all, Anita, thank you so much for bringing up ageism. And I'd love to comment about that a little bit because I'm actually teaching an aging and the healthcare system seminar right now at the law school that I'm teaching at. It's something that I have helped reinvigorate at our law school, and I'm very happy about that because these issues are so incredibly important. You know, we've talked about implicit bias a bit in my course, and you know, how do you get around that, And my students have discovered that the only time we're considering these issues for a particular group, such as aging adults or people with disabilities, is when there is like some big issue that, comes to the surface, but then everything kind of dies back down. For example, when we think about the impact of the pandemic, right, and what happened with nursing homes, we saw all these deaths in the nursing homes, and then we heard about it all over the news, and we were hoping that that would help bring change at nursing homes, for example, in terms of regulations. But things have kind of quieted down, so we don't hear those things. We saw the same things happen actually in terms of disability when we were talking about the crisis standards of care that we're developing, and it took a lot of people making a fuss because those crisis standards were allowing people with disabilities to be discriminated against, and that's one of example of where we have seen that recently. The idea that, well, a disability automatically makes somebody's life less valuable. So yeah, I mean, I don't know how we get around implicit bias. I know that there's trying to be movement to, there was a bill a while ago at the federal level that they were looking at, for example, that would incentivize medical professionals, for example, to get training for people with intellectual disabilities, for example, because what's going on is they're not getting even the training in medical school to prepare them to work with patients with disabilities. So even before we get to things like the equipment that is used, we haven't even trained our medical professionals to deal with the population of people with disabilities, and that's the place where it really has to start and change. As soon as they hit medical school, that they get experience in what it means to work with a patient with a disability.
This is Gary. These are wonderful comments, both by Barb and Laura and our other speaker, and then by Anita, of course. As much as I have concerns that this would actually be implemented, everything that I just heard is wonderful and is in the blueprint for accessible healthcare, basically by the National Council on Disability. They seem to have done a deliberative process this past year and now have issued this blueprint for healthcare accessibility. Of course, I tend to think blueprints and goals, these are great things, but let's see if it actually gets actualized and implemented. And hopefully we can all be a part of that, because quite clearly there's a lot of room for progress.
I just want to say something off of what Gary just said, because I saw that the National Council on Disability was meeting either yesterday or today specifically about health equity and disability. And I haven't gotten the chance to go to their website and see. There's supposed to be a document about health equity too, and their recommendations. So I'm interested in seeing that. I did see a couple of comments, and I know one of them was about the fact that, the research just is not there also in terms of people with disabilities. And, we're always behind, and we never have enough information, about people with disabilities to, help us do things like inform policy. So that is another thing that definitely has to change in this country.
I think it has about 4 pillars, Laura. I attended the meeting for about 30 minutes yesterday, and one of them, to Barb's discussion of accessible diagnostic equipment, the standards in the Affordable Care Act is part of one of those pillars, as is medical education and also data capturing.
We had a negotiated rulemaking committee after the Affordable Care Act passed, and I was on that representing disability issues. And we were looking at MUPs, medically underserved populations. And part of what we were trying to do from the disability world was to make people with disabilities a medically underserved population. The problem was that the designation of a medically underserved population is based on where you live. So people with disabilities don't live together anymore. I mean, they used to when they were forced, we were forced to live in institutions. So we did come up with a potential solution, and we met and we voted, the committee voted to accept what we came up with. And then after that meeting, somebody changed their vote and it had to be 100%. I still don't know to this day who that was. And so it changed, and the new rule did not get accepted. Now, what's interesting is that in this new report that came out, they did ask to have a special medically underserved population designation, which is basically what we had asked for on the committee. I'm hopeful that someday that will actually happen because we do have data. It doesn't matter where you live. We know that people with disabilities do not get the same health care as everybody else. We know that people die for no reason. So hopefully someday that will happen. One of the things that I would like to see us advocate for in the meantime, again, is to make the standards for accessible medical equipment mandatory, not voluntary. And the other thing that would hopefully come with that is the idea, it's a radical idea that shouldn't be a radical idea, that medical students should be trained to treat people with disabilities. What a concept. If you're on an OBGYN residency, you should have to do a pap smear on somebody with a disability. You have to figure out, I'm in my occupational therapy hat, when I have that on, I give my students they have to solve something. Okay, what are you going to do if this person can't get in the shower by themselves? How are you going to get them in the shower? Why can't doctors do that? If this person can't get on the table, how are you going to examine them? Why isn't that part of training? That it's not that if they can't do it, you're not going to do it. That's malpractice. You have to train, you have to examine everybody. So, it's kind of like we need a change in culture. And when I've worked in universities that had medical schools, I would offer to come in and do a lecture to the medical students. I was lucky I was in a place where they allowed me to do that, and I could explain some of these things, and here are some alternatives of what you can do. But why isn't that a requirement for all medical schools? I mean, again, I hate to go back to it, but if medical schools were allowed to discriminate based on race, national origin, religion, that we would be going crazy. The whole society, everyone would be going absolutely nuts. You can't do that. Why can you discriminate based on disability? Whoever comes before you, if you're a doctor, you're supposed to treat them. And to me, that just seems pretty obvious. I'm an occupational therapist. When I have my OT hat on, when I have my lawyer hat on, whoever comes in front of me, I represent them or I treat them. It doesn't matter to me. I do the best I can, but I know, I've been taught how to do it. I've been taught disability law. I've been taught accessibility stuff when it comes to being able to feed yourself or whatever, have a built-up handle. Why can't doctors learn that way?
Sherry, I'm going to bring you in for a second based on a comment you made earlier about having those difficult conversations with people in executive places. And I know, at least in a lot of context, when you're dealing with trying to get topics of any kind of ism addressed, the first hurdle is, I don't feel comfortable asking about this because I don't want to ask the wrong thing and wind up in a worse spot than I am. So I'm assuming you ran into those kind of conversations, and how did you handle them, and how can we use that wisdom to make the topic of disability less taboo as we're dealing with decision makers?
Thank you for that question. I will tell you that to be 100% honest with you, it does put you in the crosshairs, right? So if you recall the beginning of my comments, I said, make sure you have the data, right? What you don't want to do is go to a C-suite strategic planning meeting and have anecdotal feedback. Like, hey, I feel like we need to have, ADA accessible elevators or, suites or whatever. You want to make sure that you have that data. And I learned that the hard way, right? I went and said, because it was my own personal experience. And so I would strongly suggest making sure that you've compiled the data, that you've taken the time to understand the impact to the employees, to your team, to your university. And then I want to talk a little bit more really quickly about something that none of us have talked about yet, and it's the mental disability, right? So that was probably my area of passion. So I always wanted to make sure that the teams that reported to me were mentally wealthy, that they were okay mentally, right? And so there were some, I had a particular intern some years back, And she actually reached out to me yesterday and she said, hey, I was wondering what you're doing. And I said, I'm working towards making sure that people know how to ensure that their teams are mentally wealthy. And she tells me today, she's like, thank you so much for doing that. I've struggled with mental illness my entire life and no one has ever spoken up for me. So back to that kind of intersectionality conversation, people with mental disabilities are even harder to identify because they won't self-identify because of stigma, because of taboo. Of course, back to Barbara's comment, it's not that they're all co-located and in one area. So as a leader, I would have to come to the table with specific examples and solutions. Here's what I believe that we should do for this team, for this department. Here's how we will benefit as a result of that. And here's what happens if we don't, right? So having a project management background, you always have to have that mitigation plan. If everyone on the C-suite says, yes, we agree, Sherry, we need to make these changes, how do we do it? How much will it cost? Then you also have to have kind of a plan B. Okay, what if we don't do this? What is the risk, right? And then it becomes a litigation conversation, right? What is the risk if we get sued? And unfortunately, in my experience, there are organizations that are willing to accept the financial risk of a lawsuit. And there are more organizations that have enough coverage that they're not worried about it. If someone sues, let them sue. We've got enough money, we'll pay them off, they'll go away. And a lot to Laura's point, and then the press will die down eventually, right? Like, well, everyone will talk about it like every day for 30 days, and then they'll forget about it. And so I love the fact that you're having this panel. I love that you have your organization so that we will not allow the conversations to stop. We will have them at the highest level of organizations. We'll have them at government. We'll have them at universities. And I very strongly believe that the importance of training is where it all begins, and not just for medical professionals, but law enforcement officials. Again, if we're thinking about dealing with someone who is disabled, how are you, handling that any differently than you would someone who is not, And so first making sure that the benefit makes sense. And a lot of the organizations financially, making the changes will cost more in their mind than implementing, something that's good for the better good of, the greater good. They're like, we'll just wait it out. Hopefully nobody will sue. And sadly, Daniel, I will tell you that I've been a part of organizations that instead of dealing with a person's disability, they will find ways to get rid of that person, right? So that person all of a sudden is like, oh, you were 2 minutes late to work and you were 2 minutes late 3 times this past month, but I'm a salary employee and you also called me at midnight and expect me to work then, right? And so there are also ways to avoid making changes when it comes to corporate America specifically. But I love that, the conversations are happening, which not a lot of them were happening at corporate boardrooms years ago. And there are organizations that are calling for solutions, that are offering, let me come in and help you with your solution. And it may not be the same, it's not cookie cutter across the board. But I love that there are organizations that, like yours, that can help kind of create a boutique solution for an organization or an enterprise to address these issues per se. Thank you.
I love that. And I'm going to follow up again real quick with you, because I'm so glad you brought up the topic of invisible disabilities, whether they be physical or mental in nature or some mixture thereof. Because I imagine you bring in this data to an executive and say, did you realize out of your team of 50 people, 10 or 20 of them have a disability? And they're going to say, wait a minute, nobody uses a wheelchair, nobody has a walker, nobody has a white cane, what are you talking about? And so that's a whole conversation that we often overlook of the way that we're defining disability is not always in harmony with some of the historical stereotypes. So how do we address that challenge?
It's the same. I'm gonna kind of say the same thing, right? It is having conversations. And I made a decision in 2019 to be that voice. And that means that I had to be willing to wear that be in the crosshairs, right? I had to be willing to kind of fall on that sword and say, I will stand for what's right. I will tell you that I had an employee that reported to me several years ago, a disabled veteran, again, one of those, but her disability was not visible. You didn't know by looking at her, right? And she was being flagrantly mistreated, underpaid, the whole nine. And I went to bat for her. We both ended up losing our jobs, right? But she is doing so much better. She's literally thriving in her new environment. And so it takes courage, right? It's not work for the faint of heart. It takes courage. It takes that determination and that ability to just keep at it. Because if you can't see the disability, if it's not something that you can easily articulate, then it's going to be even less represented, right? You're going to get that much less people fighting for you. So that's why my organization exists. That's exactly why I do the work that I do, because I'm okay having those uncomfortable conversations if it's around invisible disabilities, whether it's the things that I can't change. Like, I don't know if any of you noticed, but I'm a woman of color. I can't change that, right? So if I'm going into an organization or a place and I'm experiencing, some type of unfair treatment, there's nothing I can do to change the way that I look, but I can change the way I address it. And I'm not going to be angry about it. I'm going to ask questions so that I can compile the data, so that I can make my case, so that I can hopefully bring about change. So my answer is kind of always the same, right? I want to make sure that I truly understand the problem. Sometimes it could just be me. It could just be that they don't like the shirt I'm wearing or whatever. But I do believe that as long as we continue to have these conversations, we are transparent, we are honest, and we are willing to take on the challenge that not everyone's going to agree that disability is something that people should spend time or money on, right? We've got to be willing to do the fight. So I hope that answers your question, Daniel.
It does.
Daniel, I'm sorry, it's Anita. May I just address to augment what Sherry just said so wonderfully?
Sure.
Because, thank you. Sherry, good news and bad news. I did more than enough research for the 25 years I was at Medicare's national headquarters to find out that every one of the disabilities, whether they be life-threatening or not, that Medicare decided to cover and therefore required Social Security to cover as disabilities, was only because of a family member of someone in Congress needing the financial support of the government systems. For example, the first one to be covered was end-stage renal disease, and it ended up getting covered fully. Next one was ALS. Now there are about 10 or 12 that bypass all the rules, all the waiting periods, all the financial safeguards, full 100% coverage for everything, immediate SSA, SSI, SSDI, everything clicking and being done, each one for a personal reason, because Congress writes the laws on these things. It's not written by anyone else. It's put into the prospective payment system, which every year is voted on by Congress, by both houses, put together by the representatives, and then the senators vote on it. And whatever they put in it runs 1,000 pages. Hardly anyone else reads it. The other thing was on dealing with things that are invisible. As a federal employee for my last 25 years, I found that 3/4 of the people I knew in the agency, in a federal agency with healthcare, who had disabilities, refused to self-identify because it would hurt them in their jobs. So I just wanted to let you know about that.
Thank you, Ms. Anita. Now, which was the good news? Which you said you had good news and bad news. Which one was the good news?
Good news is that once we understand that we will never be a voting constituency, because we're not going to all be in one place together every election year, okay, is to understand that the solution is corporate. It's exactly what you're doing. The solution is community. The solution is in the educational system, not on a federal level, and very often not on a state level. It's with people where they have power within a smaller scope, one by one, and we will get there.
Thank you.
The
Hi, this
irony
is
to that is that if you have a disability, you get preferential hiring with the federal government.
But
yeah.
you don't get
This
preferential work once you're in. Only the hiring system is structured. Gary Norman, please address that.
this
Yeah.
I'd like to jump in really quickly. Hi, I'm Russell Rawlings. I'm the statewide community organizer at California Foundation for Independent Living Centers, and I am just so excited to be here with you all today. This is a great group, and I'm definitely looking forward to connecting more with Pieces of Me in the future. But thank you to all of the panelists. I want to really say that, with Anita's just most recent comment, the transformation happens socially. We're not going to win this war in the medical or any other foundational place. We have to transform society at its deepest levels. And as people with disabilities, we know that loudly claiming that we are a disabled movement, disabled people together, that's the only way that transformation can really happen. And I also want to ask too, the panel, there's been an awful lot of talk about data, and we eternally find at CFILC that whenever we want to try to push something policy-wise, it is a real struggle to find any data that's useful to us. And I would love to hear some ideas about how to lead the way in ensuring that at the very minimum, individuals have the opportunity to self-identify as disabled, but even more deeply to try to figure out where and how we can strategically collect what we do have, especially whenever the barriers seem to be everywhere, preventing us from doing so.
Well, we do have the 6 questions, the 6 disability identifiers, and while they're not perfect, they do give us some data. And let me just tell you, we had to fight like hell to get those. So, and we were limited to 6 questions. And like I said, it does give us some data, and it's aggregate data, and it's not perfect. But we had to fight like hell to get that. I wish we could do more.
Thanks. And we were really deeply engaged in California's census process, and it led us to ask the question, what would it look like for some of those questions to be collected at a census level? The US Census totally ignores disability except for the ACS, which, as we all know, is less than perfect in collecting information about population.
Yeah, I that's a great question, Russell. I think back to Anita's comment, like it's literally almost organization by organization, right? Because and I will say, having been in technology for the latter part of my career, most of the information exists, right? Inside of human resource, like HRIS databases, even if you have to get creative on how you ask questions, how many, for example, and this is just an example, just FYI, right? Don't go out and say Sherry James said to do this. This is just an example. But asking questions of an organization, for example, of how many people went out on maternity leaves this year. This is just something, I'm just grabbing a number, right? You know that they had that documented, right? Because when someone goes out on a leave, they have to notate what type of leave, right? If they're out for FMLA, and then Barbara, please jump in whenever I say something that's like legally not right? So you and Laura, keep me in line. But there are creative ways to find out about why people take time off work, right? Certain organizations have PTO, right? And I believe, in my experience, the reason some companies decide to just bucket everything under one kind of PTO, it doesn't matter if it's a sick day or vacation day or bereavement, is because now you can no longer separate that. You can't say, well, this is how many people took time out for this or that, because it's all just kind of one bucket. But for the organizations that do still delineate that data, there are very creative ways that you can ask specifically how much time was lost, how much was paid out for long-term disability, for blah, 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 right? And some of that information is readily available. Some of it is not, right? Not saying that this is easy, but I would suggest when it comes to compiling data that you've got to be very creative about what is the outcome? What am I looking for? And then almost do a whiteboarding session to like, how do I get, what are all the different ways I can get to this information? Sometimes it's not as easy as going directly to the C-suite. Sometimes it's about pulling information that is already disclosed from a human resources perspective. And I hope that helps also.
In theory, if you're a federal government contractor, you have to hire 7% of your workforce as people with disabilities. So, you know, my joke is when you go to work for a really, really, really big company, they come around and say, please, if you're diabetic, tell us. It's none of our business, but we need to have 7%. We have too many employees, and if you have a hangnail, tell us. You know, whatever you have, just please let us know. And, you know, the reality should be that companies look for people who are qualified who have disabilities to meet that 7%. And you don't really see people advertising or promoting that and say, we're a federal contractor, we're hiring. If you have a disability, you get priority. Please apply for a job with us. I don't know why they can't do that. You know, how do you get to 7%? That would make sense. So, you know, it's there, but it's not being used and it's not being promoted. And, you know, it's a shame because it would make a big difference in the world if that would happen.
Well, and Barbara, to that point, it's a slippery slope, right? Because if you advertise, and this, in my experience in leadership in corporate America, like if you advertise, we need, and I'm going to say, for example, we need more Black women on our board of directors, right? Pretty much everyone at the C-suite level knows that notification has gone out. We need to hire a woman of color as a part of our C-suite. When I get hired into that C-suite position, and I think I need to address this, right? I am automatically devalued. Whatever I say means nothing. I'm only there because I had to fill a spot as an African-American female, right? And so we have to be very careful when we do that, when we're like, okay, well, we've got to advertise that we need to hire people with disabilities. And again, back to refer to what Ms. Anita said earlier, that you're like, you can get in the door, right? But will your work be valued? Will you be paid fairly for the work that you do? Are they going to just like hire you and put you, you know, in the corner with a red swing line stapler, right? Like, so, you know, it's one of those things that we've got to make sure that we think the process all the way through. The incentivization, we've got to incentivize more than just the hiring of people with disabilities. We've got to create the culture that people with disabilities can thrive in and they can grow and be promoted into, right? That's the challenge, right? I think we got to start with the hiring, but if we don't follow through, then companies will continue to just meet the very minimum and not support people like ourselves the way we need to be supported.
I'm gonna jump in here based on that and rearrange the questions a bit because I think this ties into something really well. You know, generally speaking, most surveys or stats show the disability population as being 15 to 25, probably higher percentage of the overall population. Yet the other research I have seen says that medical providers who identify as having a disability number in 2 to 3%, somewhere in that range. And it's probably higher given invisible disabilities, but there we get into the problem of self-identification that we've already talked about. And as a chronic and rare patient myself, and I'm sure I speak for a lot of us here, it would be awesome to be able to talk with someone across the exam table, so to speak, who has real world experience with chronic pain or who has real world experience with trying to find a doctor who understands their condition or has a much more advanced understanding of blindness than most of the providers I come across do. And I have personally identified this nexus of if we can't get our rights insured as patients, then it's a stretch to get those doors open as employees. But at the same time, if doctors and nurses and administrators are not used to working alongside practitioners with disabilities who are competent and capable and leaders, then we can never fully advance beyond our current status as patients who are often treated as second class. So I wanted to open this up again. If one of the three of you ladies has some comments on how we can ensure that level of equity in employment, but like you said, tying it into not just being a placeholder, but actually having the opportunity to flourish and demonstrate that competency.
Daniel, I'll just, oh, go ahead, Sherry.
No, I was hoping someone else would go ahead, Lauren.
Well, no, I mean, like, I was going to say, honestly, like, we have a similar problem really in the legal profession. And I'm sure Daniel and Gary both feel this and realize this as well. So I'm not sure that it's limited either to medical issues, but we see the same thing, you know, for example, in legal education, there are very few known, for example, and I didn't disclose that I have a disability. I also have an invisible disability. I'm visually impaired, and I don't know any other visually impaired law professors, for example. So, you know, and I think, you know, there's the same kind of problem going on now in the legal profession and trying to help us advance, you know, law students with disabilities. But I think it's even more significant in the medical profession because, you know, potentially somebody's life is on the line, right? When you're talking about medical care. And I know that there are, you know, there are groups like, I think it's called like Doctors with Disabilities. I've seen them on Twitter, and, you know, they're trying to, you know, gain momentum because like they don't even have the, you know, necessary accommodations because, you know, you know, there's that skepticism already because somebody has a disability, then how can they practice medicine when, you know, they're already, you know, insufficient because of their disability. So, but I don't have any glamorous answers to your question, Daniel, but just to point out that like in several of these types of professions, I think we have that sort of problem.
There's a big group out of Stanford Medical School of disabled physicians and other health practitioners. And they have conferences all the time. They're really helpful. And it's very interesting to listen to doctors with disabilities and how they're treated.
I'd be interested, Danielle, like, again, I'm going to go back on my data gathering thing, right? But I'd be interested to know, like, I mean, if there's a way we could find out, like what the differences are, like, you know, if there was a physician, for example, who is hard of hearing, it's almost cyclical because we talked about this, that, well, if they're not being trained in medical school, like how is medical school set up to teach them appropriately so that that implicit bias that we talked about, how much of that is based on fact? We know that medical schools aren't equipped to train folk, you know, people with disabilities effectively. So then once those people then do graduate with whatever degree, whether it's in law or in some medicine, then that implicit bias almost has like the opposite kind of data, right? It's going to show, we know these people aren't being trained the same as someone who is, you know, is differently abled, right? So it seems like a cycle, but back to Russell's point, it's something that we've got to change as a society. Like we have to start asking the questions as a little bit of everything, what consultants and doctors and lawyers and occupational therapists, like if we keep asking the same questions, because the intersectionality is amazing, right? We are all age groups, we're all races, we are everything. I think, Barbara, you said that. You were like, we are everywhere, right? There's no way to identify people with disabilities just by any one factor, which means the power is significant. We have so much power to create change because they can't look at the people that are on this call and find any one thing in common with us other than the fact that we're on this call, right? So if we continue to do things like this, if we continue to get together, have conversations, talk about what the problem is, talk about the impact, but more importantly, run for your local office, right? Run for whatever, over the school board, you know, find a way to start to create change. One of the things that we do in my organization is we do education at K through 12. We want to go into kindergarten, at kindergarten, and tell young people how to deal with their emotions, that they have feelings and they should feel them. And here's how you articulate that, hopefully to decrease the number of people who die by suicide. Now, will that change the number of people that have mental disabilities? No, it won't. But we're hoping that the education of the children at K through 12 will also educate by proxy the educators, right? And by proxy, the principals and the superintendents. And so that's that pure grassroots effort, starting where the impact is. And in this case, the impact is as early as kindergarten, right? Let's start talking about it. The same thing with disabilities on career day. If you live near a school, ask to come in on career day and talk about what it's like to work in your field with the disability that you have. So these children can see, I can still be a whatever, I can still be an attorney, I can still be a doctor, I can be the things that I've always wanted to be, even if I have that a disability, right? So we've got to be the change that we want to see, and we can only impact our sphere of influence. And if that is your job, if that's your church, if that's your neighborhood or your chamber of commerce, start with your family and just slowly increase your sphere of influence until we can see change, right?
I think it's such a valid point. And just to tie it back a little bit, for those of you who are not lawyers, fortunate enough not to be lawyers, there is what we call a circuit split, which basically means the law governing employment practices regarding individuals with disabilities in the medical field, that is inconsistent from region to region or circuit to circuit within the US. So where a candidate who has a disability may be legally protected in one part of the country, they may find themselves barred from applying for medical school in a different part of the country if that school has decided that seeing, hearing, walking, talking, movement are essential functions. The courts in certain parts of this country, for whatever reason, have upheld those as being vital. And so that does tie it back to, especially in certain areas, this has to be community and grassroots led, because the legal protections just are not there at this point.
I mentioned something about, I'm sorry.
I'm sorry. I just wanted to augment what Daniel just said with going way back to the mid 1960s when I first had to start using a wheelchair. And I was in New York City at a city university thinking I was going to minor in education. And when I applied, I had to take a physical from the School of Education to be able to minor just for a substitute teacher, because my major was something else, because the city teachers union required it, because they were the ones who oversaw the health insurance. They ran a finger down my spine, hit all of the bad vertebrae, and said, you cannot get a teacher's certificate because you'll mess up the cost of our healthcare insurance. Just thought I'd share that. And that's what happens now. Daniel's absolutely right. Med school, a lot of other certification areas have requirements that are still allowed within states and within all of the top professional organizations.
I just wanted to mention that I mentioned something about Stanford. Stanford had something called SMAC, the Stanford Medicine Abilities Coalition, and they recently changed the name to the Stanford Medical Alliance for Disability, Inclusion, and Equity. And they run doctors, medical students with disabilities, and they started there, and they have like international conferences now. They invite people from all over. So there are medical students and nursing students and occupational therapy students, physical therapy, that are supported all over the world at these annual conferences. And Stanford's a big deal, so it's pretty accepted. And they all have disabilities. It's started by doctors and others with disabilities. So it kind of gives me hope that the world is changing a little bit.
And Barbara, what would be awesome? I think like what if more people knew what you just said, right? I think with the power of social media, we're so used to just kind of consuming all of this. It's usually negative, right? Data or information. Like, what if we use a tool like social media to promote the people who are doing it right, the schools that are doing it right, the organizations that are doing it right? And again, if there's nothing in common with the folks of us on this call, but we're all like, hey, great job, Stanford. We understand that you have this program, and that ends up on my LinkedIn feed and my YouTube channel and whatever. The one thing I do remember well about corporate America is very competitive, right? And you don't want to see your competitor doing something better than you, faster than you. You want to be first to market. And so I love that you gave that bit of positive feedback, because if we were to take that and amplify that, and say, hey, here's someone who's doing it right. Here's someone who's identified the problem. They've done something towards the solution. And here's what we think the valuation of that is. I think that's a great start. I think if we could, everybody knows some company or some organization that's doing a better job, if not perfect. And I think they should get kudos for that. Maybe that would encourage more people to change.
Yeah, I agree. And the irony is that it was started by physicians with disabilities who were being picked on, I'm using that term on purpose, in medical school because they were physicians with disabilities. And, they're able to support other doctors and, therapists and everybody else coming behind them to see that, you can do this. You can do it.
Yeah. And then that's a good thing that, like when it comes to allyship, that visceral response. So what you just said would resonate with so many people, because a lot of people were picked on in school for some reason or another, right? Maybe it wasn't a disability. It could have been anything. But when you have those kind of conversations and you use those words, like the reason this was started was because these doctors were picked on in medical school, that triggers an emotive response. And you're like, oh man, I remember what it felt like to be picked on when I was in school. And I wouldn't want that for my next generation, for my children or my children's children or whatever, right? So I love that
they're leaders. Yeah.
And now they're leaders, right? So yeah, I think that's great. I would love to hear more about programs like that.
Yeah, I put their name in the chat.
Is there any possibility that someone could find some data on how many patients have a hard time walking into, whether it be the office or the examining room, with a physician or other healthcare provider who has a visible disability? Let's put it this way. This country would have never elected Franklin Delano Roosevelt president if they knew people were holding him up.
Yeah, exactly.
Yep. We haven't talked about our new reality yet as far as telehealth, and I think this ties in a particular way here. As a rare patient, for those of you who aren't familiar with this reality, and most of us who have rare conditions don't have the privilege of venturing into a provider's office and assuming that they are up to date on our condition and how it may impact whatever we're there to be seen for. Honestly, that is a distinctly rare occasion. More often than not, we find ourselves educating the provider before they can actually treat us, or winding up in a situation where the medical advice is completely disregarding our condition and is thus useless. One of the reasons I personally, and I think a lot of us, were so excited to see telehealth come on board by virtue of the pandemic was because, in theory, it opened up the idea that we could see specialists from other parts of the state, other parts of the country. For those of us that have traveled, it would be so much easier to be seen by a provider across the country online versus having to actually get on a plane and go there like so many of us has done. Yet that's not been the reality the way that we would have hoped. So Laura, I know that's in your wheelhouse, is one of the conversations we had. So I wanted to hand the ball to you and let you take that.
Oh, well, thank you so much, Daniel. You're speaking my language here. But first, I'll just say I started actually working on telehealth and researching it before the pandemic. So it's really been fascinating for me to see the development that very quickly happened because of the pandemic. And like you said, Daniel, certainly there are potentially, and I say potentially because there are some significant issues, a lot of possible benefits of telehealth for people with disabilities when we think about things like the cost just in general of healthcare, when we think about things like transportation costs, costs for personal care assistance, medication management, coordination, and there are these types of benefits, but there are a lot of significant barriers that have to be considered. I think what I am finding from my work that's most interesting is the barriers are ones that have existed for some time. My most recent research that I have been doing has been focused on, for example, the issue of the digital divide. What exactly am I talking about when I'm talking about the digital divide? Well, that's those who have technology access, those who don't, but that comes in a lot of different ways. First, we're thinking about, access to the actual technology as far as the internet. Many people in this country still do not have broadband. We know from research that that impacts many people with disabilities, especially since they're living a lot in rural areas. There's also the access to the technology in terms of the devices. People don't have smartphones, they don't have tablets, they can't afford those particular devices. I actually just read some research today that 20% of people with disabilities don't have access to all of those technologies. That's what the statistic is right now, 20%. That's very high. So we've got that issue. We've got the affordability, because we know that there's a greater portion of the population of people with disabilities that are at more, poverty-stricken levels than the general population. And so we have that also roped into the accessibility. There's also accessibility, which is a big one for people with disabilities in terms of, can they actually use the technology? And we know that obviously no two disabilities are alike, even when we're talking about somebody with the same type of disability. I'm visually impaired, but somebody else who is visually impaired may have different technology needs than I do. And are we designing our technology in such a way that people of different types of disabilities are able to use the technology? There's also research already out from looking at the use of telehealth in the pandemic by people with disabilities that, the use was different based on the type of disability. Why? That's because of the design barriers that we have right now. We also have significant legal barriers. Right now, our laws are in a patchwork in terms of telehealth. We're trying to figure out what's going to happen in terms of regulation after the pandemic. We've had a lot of relaxation of regulations, for example, with Medicare and Medicaid, that have opened the doors for a lot of access to telehealth that we didn't have before. And the questions are now becoming, what's going to happen after this? We don't have any national or federal telehealth policy. So most of it is coming at the state level, and the states, are all over the place in terms of a number of different issues. And particular to people with disabilities, we have still enormous problems as far as website accessibility. This has been going on for some time in terms of the Americans with Disabilities Act, and the fact that the Justice Department was charged with actually creating guidance as far as website accessibility that has never actually been created. So at this point, the ADA was written in 1990. and it was focusing on physical places, right? We didn't have the technology that we had, that we are in right now to think about. I mean, in general, people think, well, the ADA was broad enough that it should cover the internet, which makes sense. But then when these issues have gotten to the courts, we've seen the courts take different positions on internet accessibility, even though generally we think that, portions of the ADA should cover accessibility and telehealth. So I'm just going to leave it at that. That's kind of the big issues that we're seeing in a nutshell right now as far as disability. And obviously, many of these things, as I said, are issues that we've known that have existed, but that, if telehealth does become a regular part of healthcare, that we need to start addressing and looking at in terms of people with disabilities.
If I could add to what Laura just stated, because of my time in IT, right? I remember when the ADA Act came in, people were like, "Oh, we've got to go and revamp our websites to make sure that they are, people that can access them," right? I think the same challenge that I give to some of my clients now when it comes to diversity and mental wealth and mental disability is the same thing that we have to do when it comes to accessibility to websites and telehealth. We had an example in one of my clients' sessions where we blindfolded. We actually placed something around a person's eyes and told them to navigate to a website, right? And like, okay, we need you to go to google.com, right? Just do it. Just type it. You know how to type however many words per minute. And it was interesting to see the shock and horror, right, in that person's face. I'm like, I don't know I can't Google anything if I can't see it. And again, that's that implicit bias that I assume everybody can see and get to Google the way that I get to Google. So why is there going to be a difference? It almost takes people to physically be in that place, to be able to say, okay, like Miss Anita said, how many doctors I want you to try to get into your office on a scooter. Like, I'm going to sit in this chair, you use my scooter, and I'm going to watch you get out of your car and get up here alone, right? And so some of the training that we're doing, I think would still apply even from a telehealth perspective. Even if it's the medical provider, right? Have they had to go through a telehealth appointment? Have they had to do so? And if they did you have to do it, like put 2 earplugs in, right? Try to have that telehealth appointment where now you can't hear as well as you used to be able to hear. What was that experience like? And we go back to that emotive, that visceral, wow, I didn't like that. I didn't like the fact that I could tell that Laura was speaking, but I couldn't really hear her. And there was nothing else showing me what was being said. So now my telehealth appointment, as hard as it was to get to because I didn't have access to internet, and I had to use my neighbor's computer, but then I also had a hard time hearing and or understanding. I believe that the training that we all keep saying and we keep reverting back to, it has to include those students feeling what that feels like. You have to experience it in order to want to make a difference, right? I think we can talk about it all day, right? Because we know what it feels like. But if we don't incorporate that into those trainings, when it comes to software developers writing code, then some of your testing should include testing it while blindfolded, testing while wearing, something to change your hearing ability, so that they can say we've actually gone through and we feel what it feels like. And I know that sounds crazy, like we're talking about technology, but the people who are writing the code are people, right? They're humans, and they only know what they know. They've been given a set of a document that says, hey, write this software, make this telehealth software work, period. And they are going to only write to what they've been told, as opposed to making sure that there's some QA in there. Like, okay, a requirement has to be not just because the government said so, but from an end user perspective. Like, have you identified all end users from all capabilities and all disabilities? And that's possible. That's a lot. That's doable from a technology perspective, even if it's just reaching out to those technology providers that the name of I can't remember the name of any of the telehealth providers, but if we're reaching out to them to ask, what does their process look like? What does it look like when you test telehealth for people with disabilities? What accommodations do you have in place? Again, asking those questions sometimes can encourage those developers to add more QA time, more quality assurance, and make sure that people with disabilities are being covered even in that aspect. Because I know now they're probably not, right? They don't have to.
Yes.
They're
Yes,
not going
Sherry.
to.
Yes. The design of the software, and you also made me think of something else. And this, we started out talking with Barbara about medical equipment, right, in the physical office. But we are also seeing the use of, special equipment in telehealth encounters as well. So that would mean, the patient at home has some sort of a device that they would have to use for the telehealth appointment. And, have we thought about whether or not those technologies are being designed for the person with a disability to be able to use? So, like telediagnosis, those types of things. That's another issue that is frequently being raised.
One of the nice things about telehealth is everybody kind of looks the same. So, you don't have, they can't tell if I use a walker, if I use a wheelchair, and, we're all sitting. And so, people are kind of treated the same. You don't get that look when you come in a walker or a wheelchair or whatever. You're just kind of looked at as a person first rather than the device, which is nice.
Yeah, and I would point out another thing that we've seen also. We have talked a little bit about mental health and disabilities in that area, but a lot of the increase of telehealth use during the pandemic was people with mental illness feeling much more comfortable using the technology to have appointments than having to actually go in. So it's not that it's not without its issues as well, but that particular group has seen a large increase in telehealth use.
Agreed. I'm gonna have a funny story, Laura, now that you brought that up. So I work in this mental health space. I am an advocate for therapists and all of it, right? It's what I do for a living. My son is 14, and maybe 2 years ago, it was pre-pandemic, he and I he wanted to go to the movies. So we made a plan to go to the movie theater. But before, I had to go to a therapy appointment. And so I took him with me. He sat in the lobby. I went in the back. I had my therapy appointment. I came out and we went to the movie, which is literally across the street from my psychiatrist's office. So we sit down, and I'm sure they do this everywhere, but before the movie starts, there are like local ads. So you can buy advertising space before the movie starts. So we've got popcorn and we've got snacks, and we've got to like kind of squeeze it. It's a Marvel movie, so it's packed.
Sure.
Like every seat is full. And we squeeze our way in and we sit down, and one of the commercials that plays on the screen is the lobby of my psychiatrist's office, right? And they've got this beautiful blue velvet chairs. And my son's like, Mom, look, that's your doctor's office that we just left. And it's like, so psychiatry, blah, 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 blah. And I work in this space, and I was mortified. Like, I was absolutely 100%. I'm like, shh, don't say that. Like, we can't talk here. But it was a lesson to learn. Like, I can't imagine seeing an advertisement at a movie theater for psychiatry, right? And I know that there were some people that struggle with mental disabilities that saw that and it definitely said, we have telehealth appointments available. People who don't worry about the stigma of walking into a place and then having their child kind of tell everybody in the movie theater that we just left. But it does give you that comfort of being able to do it in the privacy of your own home without having to walk into a place and have that additional stigma. So yeah, thank you so much for bringing that up. I feel bad.
Absolutely.
I probably should. No, but that's a great point. And a lot of people who don't have access to even health insurance can still access telehealth for mental disabilities. So that's a great point. I'm glad you brought that up.
I've also heard the perspective from doctors as well that they like it as well because they can actually see into their patient's home a little bit and see what their environment is like. So that's another thing.
So we're going to open it up to questions again here in a moment. So people in the audience, you can either type your questions in the chat or be ready to take yourselves off mute once we hear from the panelists one more time. And we've already covered a lot of solutions and a lot of ideas moving forward, not just complaining about where we currently are, but what can be. So I'm going to ask each of you to outline your vision of how we get there, how we build those coalitions. And I'll say, as I was browsing through the registration forms over the last couple of weeks, I was really excited because we have, of course, we have advocates and we have, people who are, one of the registrants was the co-founder of hospitalwatchdog.org. But on the other side, we had pharmaceutical representatives. We had someone who is very influential in healthcare administration within their hospital network. We had the spectrum of people who wanted to come and learn. So how do we capture that momentum and start creating a new tomorrow? So I'll let each of you go in order and give us your thoughts there.
Okay, I'll start. So I think I mentioned a couple of these before, but kind of making changes within your circle of influence. If you see anything that I've recorded in the past 24 months or so, it talks about being honest and open and transparent about my experiences. I had the opportunity to have a very interesting conversation with the First Lady, or what do you call it, ex-First Lady, Michelle Obama. And she said it's much more difficult to not like a group of people if you know a person that's like that, right? So for example, if it's harder to be racist against people that don't look like you if you have the person that you know. Like I know Sherry James and Sherry's great. She happens to be a woman of color, but Sherry's a great person, right? And so I think that if we try to expand our sphere of influence, if everyone in your circle looks just like you, then you've got some work to do, right? If everyone in your circle thinks just like you, then you also have some work to do, because the more diverse your thinking, the more diverse your groups that you're involved in, the bigger the impact of the change that you want to see, right? So my suggestion is, like I said, run for some kind of local office, show up at your local K through 12 institution, or even a university, an education, a place where we know that it has to start. It has to start with people knowing what the problem is before we can expect them to make a change. And so in every conversation you have, make sure that it's inclusive, make sure that your team and your tribe and your neighborhood is representative of all of those groups, right? Whatever pillar that might be, because that's how you can influence change, because it's a little bit at a time. Grassroots is one blade of grass at a time. But we don't cut it that way, right? We've got to cut it all at once, right? So we make sure that we're having the conversations consistently, honestly, being transparent, and being willing to just stay in for the long haul, because it's not a quick fight. Your turn, Laura.
Okay, thanks. Sure. So, being somebody who writes about law and policy, my main idea, and one that I try to push, is making sure that people with disabilities are being thought of at the very development of the policies that we're thinking about. So with the work that I'm doing on telehealth right now, it's really important to me that we're talking about the needs of people with disabilities, so that as these policy decisions are being made, that people with disabilities are first and front in terms of these policy issues. And I think hopefully we are going to see development in that, because I know, for example, at the federal level, the Biden administration hired someone specifically as far as disability, in the White House to ensure that that would happen. If that actually plays out, we will see. But in terms of thinking about, policy making, just making sure that the voice of people with disabilities is at the forefront of these issues as they develop, and not that we become an afterthought. And I would echo Sherry's point about just in whatever community and space that you're in, trying to bring attention to disability. At my law school, for one, I'm a new professor there. I have been very outspoken with my students about having with a disability and in the law school community. And I found that very important for the students, especially, to enable them to feel more comfortable, and they have, in terms of sharing, their experience with disability and their needs. So, whatever profession or work that you do, trying to make sure that you help to bring the voice of disability to the table in whatever way that you can.
And I guess I would build on what both of them said. I think that one of the things that as people with disabilities, we really haven't been, we haven't been as organized. I mean, there are a lot of us, we have leaders, but we haven't really gone to the average Joe or Jane person with a disability and said, you can make a difference. And I think that that's really important. I think that we need to teach people how to advocate more from a very granular level. When somebody calls you and says, I'm calling from this campaign and I want you to vote for so-and-so, to say, well, what is his plans to address the needs of the disability community? And, I think it's really important to let these politicians know that this is important to you, and to let people in our community know that you can ask these things, that you can, you can be your own advocate. It's not rude if like the guy who when the guy in Wisconsin was campaigning and he was telling him, I want to do this, I want to do this, and the guy said, I want curb cuts. Imagine the power that we would have if we could get people in our disability community to do that. What's important to you? What do you want to see? Politicians are going to talk about what's important to them and what they think is important to you, but they don't know anything about the disability community for the most part. Most politicians just don't. So it's our job to teach them and to advocate and to tell them what we want. I mean, I just, I can't help it with that story about how powerful that was when he said, all I want is curb cuts. I don't care about any of that. And so the first curb cut bill in the country got written. We have the power to do that in so many other areas. I mean, the idea that we could make accessible medical equipment mandatory. If every politician called somebody with a disability, was campaigning, and every person with a disability said, I want accessible medical equipment to be a mandatory requirement across the country, that's powerful. And, as the disability community, we could hold that power and make it work. And I think it's just a matter of teaching our colleagues and our compatriots how to do that we do have power because we have numbers.
Absolutely. So we do have time for a few questions. I'm going to kick it over to Christy for a minute if we have any questions from the chat box.
Not as of now, we don't have any. So if anyone would like to either enter one, or you can speak up and ask your question, however you feel more comfortable.
Absolutely.
If I could just explain, because this is a perfect disability answer. I've been speaking through this when I've had questions or comments, because this meeting is a perfect example. You have no ability for me to, I can't use the chat function. As a result of that, I have no way of participating on a little on the side or below the lines comment on anything. If I don't say it, it's as if I didn't exist here.
Yep.
And I think we're keeping this far too narrow, not even using ourselves as a good example on how to be more inclusive.
Well, but that's why we've had, that's why we have it to where people can come off of mute and ask rather. But the reason I bring up the chat box is because I'm also aware that we have several people who are using closed captioning and may not be comfortable or able to come off of mute. That's why I've specifically gone for both.
Right, but I've attended many federal meetings as well as university and other organizations that the only way to submit a question or a comment is by a chat box.
Fair enough. Absolutely agree, and that's one of the reasons why we didn't want to do that.
Great point. I'm hoping that with the pandemic and the sheer numbers of people that are required to use this technology now having increased exponentially, I'm hoping, this is fingers crossed hoping, that we'll be able to see more inclusive technology, because we're not going back to the way things used to be. I think that the use of technology will only increase, and as long as, organizations like Pieces of Me and Daniel's team stays around and we keep having these conversations and bringing up to the people at Zoom, by the way, how can we come up with something that can be accessible for those that cannot use the chat function? And to Laura's point, the best ideas come from university students, right? This is an awesome challenge for, maybe a University of Texas at Dallas, and there's some amazing software engineers that come out of that program. Hey, how do you make Zoom accessible for those who can't use the chat feature, right? And so again, that's thinking outside of the box. That's not being angry with Zoom for not doing what they were supposed to do, but coming to them and saying, hey, how about this? How about putting a challenge out to all of the local universities to see who can come up with a way to make Zoom meetings more accessible to those who can't use all of the features, right? And so that's kind of one of the examples. So I'm glad that you brought that up. I think that there is opportunity for everything to get better: technology, communication, leadership, law, right? It starts with the conversation, and it starts with those that can be, proud enough to speak up. So thank you for that, Anita. I think that that's a very great point. And I think there's probably some ways that we can encourage, with Laura's help, Laura and Barbara's help, there's ways that we can encourage organizations to make those changes.
This is Charlene. This is Charlene, panelist and Pieces of Me. Thank you. This has been an excellent conversation. I have been frustrated for years in trying to get the ophthalmologist to the table to actually talk about the patients that they're treating. And instead of sending them home and saying, oh, well, you're blind now and there's nothing else I can do. There's nothing else that can be done. It's the end of your life. I've been really trying to get them into the conversation. And so I'm looking forward to engaging more and seeing more of this conversation. So thank you.
Thank you.
Thank you, Charlene. And Gary, did you want to ask your question, or was that something you were just kind of putting in the chat? Gary Horton.
So Gary's question says, how can we encourage corporate America to lead? 15% is a big number.
And what I mean by that, just to put a finer point on it, it has been my experience over my 60 years of life that when corporate America decides, things change. And the way that corporate America changes is when their pocketbooks change. And 15 to 25% of the population is a big number. Have we thought about those types of solutions to engage corporate America in a number of ways, in a language that they understand? Because they, in my way of thinking, have power over the politicians more than the people.
That's a great question. I think that's kind of one of the solutions that we've alluded to several times, in this conversation, is making the changes at the organizations that people work with and for and through. I know that Phoenix Speaks, my for-profit organization, that's what we do. We go into organizations and we can train leadership on how to make these changes. And it's much easier as a consultant to come in and say, hey, here are the changes you need to make sure that you are more diverse and equitable, inclusive, and people feel like they belong, whether it's from a disability perspective or any of the other protected groups. But I believe that the risk is so great for those leaders that they don't want to own it, right? They don't want to say that I was the person that made the change or I suggested whatever. So organizations like Daniel's organization with Pieces of Me, and like mine and other organizations who we were created for such a time as this. This is why we are here, so that those organizations can depend on us to come in and do that training, and and have their leaders be held accountable for making sure that their teams look like society looks, right? It's not an overnight solution. It's not something that'll be solved right away, but there are organizations that are ready and willing to help corporate America to take on that uncomfortable conversation, because we know they don't want to have it, right? We know that they're not even skilled or trained to have those conversations. And so I think it's more the more topics and conversations that we can have similar to this, the more organizations and groups and coalitions will be formed that organizations can lean back on and say, you know what, I want to hire this company to come in and do this training and bring us up to speed so that we are no longer a part of the problem.
There are corporate leaders that are out there. I think I spend a lot of my time absolutely promoting them in every way I can. Promotion is important to corporations also. I agree with you, Sherry. Absolutely. The consultants help, but you know what? When people with voices promote corporations that are actually doing this work, I would cite DTE Energy. They've been very ahead of the game. Jerry Norcia posts several times about some of the changes that he's made within the organization. I invited one of my colleagues from Pfizer. They are really leaning into expanding diversity within their organizations. And these companies, in my opinion, should be heralded from us, from organizations like Pieces of Me.
The other thing is that by law, if they're federal government contractors, under Section 503, they have to hire 7% of their workforce as people with disabilities. So, and that's like 98 to 99% of all employers. So I think that's something that we need to look at. That some are trying hard and some don't know how and don't know who to reach out to. And I'm not saying they should do it to reach the quota, but they should do it because it's the right thing. But if they need help with that, then there should be ways that they can reach out and come to the disability community, and not just through necessarily advertising, but partnering. I do some work with the United Spinal Association. People at United Spinal, our members, would love to have jobs, and I do some employment promotion for a group and teach people how to look for jobs and stuff. And employers that come to us and say, we want to hire people with disabilities, but we're not good at it. We don't know where to advertise. We don't know what to do, and we'll tell them, well, let us know what jobs you have, and we'll let people know who are members of United Spinal, and we'll see if we can make some matches. And I think that that's an important process, to look at reaching out to groups like that, and reaching out to organizations that whose members have disabilities and want to work. It's not just vocational rehabilitation. It's people looking, where do I look for jobs where I know that they're not going to give me that look when I roll in the door, or if I have a disability. How do I do this? And are they going to be willing to make accommodations? Do they know what those are? If I tell them I need to have my desk raised, are they going to do it? And I think that that's a piece of it, is how does a group like this help educate employers as to how to do this, how to do it right, how to make people feel comfortable. And if you have a question, you can ask us. And we're not going to look at you with a look because you asked a stupid question. You're asking a question you want to know, and we're willing to work with you.
And Barbara, and it's simple as with using applicant tracking technology, like when applying for jobs. It's as easy as integrating our office space is ADA accessible, right? If you were to just plop that into a job description, then it makes it a lot easier for people with disabilities to feel comfortable applying for that job, right? So that's some of the feedback that we give our clients, our corporate clients. How are you making sure that people with disabilities will feel comfortable coming to work with you? Where in your job description, where on your About Us page, on your company site, where did you say that your offices were ADA compliant and accessible? And where do you have pictures of people of different abilities on the website, or do they all look exactly the same? Then by default, I'm going to assume that you don't want me there, right? So
Yeah.
there are solutions back to your question, right? That's how we can educate corporate America on small
There isn't, I'm sorry, there is an ADA problem that actually makes it worse for all of us. First of all, before the pandemic, half of the American working public works for small business by federal definition of what's called small business. None of these requirements apply to small businesses. Anyone with less than 100 full-time employees,
Oh, no, no,
or
no.
if you
It's
go the
less,
financial route by how
it's,
many millions of dollars you're
it's not
building.
100 employees. If you have 15 or more, you have to comply
Okay,
under the
even
Rehabilitation
at
Act.
15, what's happening now is the pandemic added in 20% of American jobs are gig workers. They're not going to be counted in anything because they're not working in offices or in facilities on a regular basis. And we have a real problem because we can't even get people to agree on defining disabled or physical limitations, or allowing people comfortably to talk about what might be wrong with you. Because if I can't talk about what issues you have that might limit your ability to be like John Q, who can do everything physically, then we can't accommodate properly. We can come up with something that's uncomfortable, that's close, that's annoying, and would be over the so-called reasonable expense.
Well, you can ask people if they need a reasonable accommodation to do their job, to do the essential functions of the
Most
job.
people who have not worked because of their disability can't even give a correct answer to that.
Well, I think it depends, some of that depends on how we train people who do the interviewers, how we train them. And keep in mind that a lot of these companies that are big are desperate to find 7% of the workforce. So they are going out of their way, they are doing trainings. And the nice thing is that when they're interviewing people now, they don't know if they have a disability because they're seeing like us from the waist up, and you can't always tell. And I'm finding with the work that I do with the United Spinal Association, I'm finding that people are getting jobs a lot easier now because of that, because they can work from home. And that's considered a norm now. And they don't have to ask for it as an accommodation. So
What happens when they have to go into an office?
they
Because as
explain that they need the
IBM
accommodation to
has
work from home.
canceled all of their work from anywhere except in office 6 months before the pandemic because they found it was financially and creatively killing their company. They called
Well,
everyone internationally back
but
to an
it's fair.
office.
Okay, it's fair to say you were able to do it for me before. It's a reasonable accommodation for me now. That's the legal principle that we're talking about. So if they were able to do it before, they can do it now. So this should be a situation that opens the door for a lot of people with disabilities to be working remotely. And I can tell you that there are several companies that specialize in remote work. There's one called Virtual Vocations. And Virtual Vocations, I met with them with the United Spinal Association, and we explained to them that we have employees that want to work virtually, and they didn't know about the Rehab Act. They didn't know about reasonable accommodations and letting people work from home. And when the pandemic hit, oh my gosh, you go to their website now and it just there's tons of remote jobs on their website. And that is such an advantage for the members of United Spinal and everybody with a disability. But they were so appreciative to us that we explained to them that companies have to hire 7% of their workforce as people with disabilities, and we can provide you with access to people with disabilities. So that really made a big difference for them.
Can you put the name of that organization in the chat?
Sure. There are 3 organizations that specialize in remote work, remote jobs. I'll put all 3 of them in there.
Thank you. There are other organizations as well that offer and staff to people with specializing in people with disabilities. That is a space that's becoming more and more occupied. And I would also say, I just wanted to make sure we put this in, hybrid work and remote work is never going away. There are able people that will not go back to the office. There are entire IT groups that will never go back to the office. There are HR groups that will never go back to the office. The cost of commercial real estate is dropping because these huge assets that these companies have invested in, people aren't coming back. And we have to leverage that. We got to take advantage of that. We got to shoot the gap while this opportunity exists. That's what I think. I think that's the future. We need to own the future. We need to be at the forefront. That's why I'm in this business of trying to staff and place and encourage individuals to think big. Everything is possible right now.
And Barbara, if you wouldn't mind emailing those resources to me or Christy as well, and we'll get those out to anyone who via email who can't access the chats, and
I will do that
on the website.
Okay, and I just want to point out there's one called disabledperson.com, and it's not politically correct, but they've been around for a really long time. And when they started their website, they promote to 503 employers, and they started that when 503 came around. So at that time, it was politically correct to call it disabled person instead of person with a disability. So I'll put all three in, and then I'll email them to you also.
Awesome.
And I just want you to know that I have met with these people, and I know that they're all legitimate.
Thank you for that. That's awesome. And Daniel, I just wanted to remind you also, Daniel and Christy, you can always hit the ellipses at the and hit save chat, and then all of the other kind of feedback back and forth that did happen in the chat. If you want to pull that out and add that to the email to your participants, you can do that as well.
That is a great idea. We will do that. Christy, you're in charge of that.
Thank you. I'd love to be.
Yeah, this disabled person keeps putting a space in between disabled person. Let me see if it works now. But we looked into that one because it kind of looks fake. When you go to their site, it's almost like those of you who are old like me, the old-fashioned ticker tape from the stock market where it would come out and just keep coming and coming. That's what it looks like. You just keep seeing jobs posted and posted and posted, and it's like, this has to be fake. And we met with them, and we learned that the guy who started it, I want to say he was a pharmacist with a disability, but when he had this disability, he came up with this idea of contacting employers that have to promote jobs, that have to hire people with disabilities. And so they advertise on this site, and they're real jobs, but there's advertising from all over the place. I mean, I looked something up for pharmacists in California, and I think there were like 550 jobs opening in California. So, she didn't want any of them, but she got a good job. But, just you see all this stuff come about, and it's not fake. So
the timing is great between what Gary Horton said about getting corporations and showing places where they're doing things correctly and promoting that. And when you talk about staffing organizations, the biggest problem, and that's why being a macroeconomics person professionally, that the hybrid office may not be here to stay. There will be some people eligible for it, but businesses are finding themselves failing at future planning and being able to work where our communication in this has been dealt with in person, and the staffing and the training people have not yet put together packages for management, for training, for equal access. It has nothing to do with handicaps. But when you work by yourself, how do you get promoted? How do you become a team leader? It's not who types faster. It's how do you have a meeting without people on a big screen looking like Hollywood squares because they have little nodding heads. every time you say something, which doesn't tell me if they've really gotten it. Okay. Now's the time for those of you in those fields, please develop the professional training, teaching, and staffing packages that, without even calling it being inclusive, just includes everyone. And I mean everyone, and turn that into our norm.
I think that is a great note for us to end on for this second.
Absolutely.
I'm gonna tell everyone how to really lean into being a part of Pieces of Me and help create solutions in a moment. But before I do that, Mr. Horton, tell everybody why they should be in this very same Zoom room in 4 weeks when you're leading a discussion.
Thank you, Daniel. I didn't know you were going to do this, but yes.
I didn't either.
next month on the 24th at the same time of 24th of March, we will have a panel discussion called what happens when the lights go out? I'm blind. It's for individuals between 35 and 55 that have lost their vision. And we're going to have a very, very frank discussion about how do you get from that point of blindness back to employment, myself included. One of the panel members will be the head of the Bureau of Services for Blind Persons in Michigan, who is in fact blind, another entrepreneur from here in the Detroit metropolitan area, and myself will be sharing our stories, offering solutions. And I think anyone that knows someone that is visually impaired, knows someone that is low vision, knows somebody that is possibly losing their vision, this would be a very helpful discussion to participate in. I will be promoting it quite heavily, and I hope we can look for all of you to join, because there's something for everybody to join. Even though I'm blind, these same issues happen with people with all types of disabilities, which is why this is such a fantastic organization, right? It's the Justice League of Disability. That's what I believe. So thank you, Daniel.
Thank you. And I didn't know I was going to do that either, but like I could explain it myself, or I can let you do it. I think you did a far better job.
Can we just talk about the Marvel, like the Justice League? Like, you need to caption that. You need to feel that and use that. That was awesome. That was a mic drop moment, Gary. You nailed it.
Yes. So, y'all, we've had a great conversation this evening. We have looked ahead at solutions. We have talked about building coalitions. We've talked about lifting up organizations and businesses that are doing the right thing and creating greater awareness through highlighting positive examples. That is the very core of why Christy and I started this organization in 2019, when it's been a great struggle to get to here and to get to where we are going. So we're approaching the top of the hour. I'm gonna try to keep this brief, but we need everyone to come aboard, be part of this movement, this community we are building. There are all kinds of different ways to support what we are doing. They are outlined on the website, the social media, or you can get in touch with us individually to figure out where you fit. But this is what we're doing. We're talking all throughout this year and beyond about solutions from all kinds of different angles, having the conversation that needs to be had, and then we are taking what we learn and putting it out into the world so that it can raise the level of consciousness. So with that, I'm going to thank our panelists yet once again, and thank our audience. Panelists, you were exactly what I hoped you would be, and then some. I knew you would rock the stage, and you did. Audience, it's great comments and questions. Thank you for your participation. Thank you to our interpreters for coming in at the last minute and making this program inclusive. And again, we hope to see you all next March, and next month and beyond. And we hope to have you come be a part of this, come be a part of this magic that we have created. So with that, I'm going to thank you and say it's been a great conversation.
Thank you, Daniel. Thank you, guys.
Thank you everyone so much for coming, and thank you to all the panelists as well. It was a great conversation.
Thank you all. Take care.
Bye.